Acute HIV infection is symptomatic early HIV infection. Early HIV meaning within 6 months of acquiring the HIV infection. While most of the individuals with acute HIV infection have at least one symptoms in the first 4 weeks after primary HIV infection, these symptoms are usually mild, nonspecific, self-limited, and never brought to clinical attention. Some patients present to care with more severe symptoms known as acute retroviral syndrome or seroconversion illness. Symptom onset occurs acutely around 2 to 4 weeks, ranging 4 days to 8 weeks after viral infection. The symptoms of acute retroviral syndrome lasts on average 18 days. The resolution of symptoms coincides with the setting of a viral replication set point around 30 days after the initial viremia. Without treatment, high viral load and increased severity and duration of conversion illness are early predictors of poor outcome. The symptoms of early HIV infection include constitutional symptoms, meaning systemic or general effect of HIV infection, which includes fever, fatigue, myalgia, which is muscle pain, are the most common symptoms reported by patients with acute HIV infection. Fever in the range of 38 to 40 degrees Celsius is present in the vast majority of patients with symptomatic acute HIV infection. The second one is adenopathy, which is enlargement of lymph nodes. Non-tender lymphadenopathy, primarily involving the axillary, cervical, and occipital nodes, is also common. Adenopathy often develops during the second week of the illness, concomitant with the emergence of a specific immune response to HIV. The nodes decrease in size following the acute presentation, but a modest degree of adenopathy tends to persist. Mild hepatosplenomegaly also can occur. The third one is rash. A generalized rash is also a common finding in symptomatic acute HIV infection. The eruption typically occurs 48 to 72 hours after the onset of fever and persists for 5 to 8 days. The upper thorax, collar region, and the face are most often involved, although the scalp and extremities, including the palms and soles, may be affected. The lesions are characteristically small, 5 to 10 millimeter, well circumscribed, oval or round, pink to deeply red colored macules or maculopapillars. Vesicular, pustular, and articular eruptions have also been reported, but are not nearly as common as a maculopapular rash. Pruritus or itching is unusual and only mild when it presents. Gastrointestinal symptoms are the fourth one. Since the gastrointestinal tract is the primary target during acute HIV infection, patients with acute HIV infection often complain of nausea, diarrhea, anorexia, and weight loss. More serious gastrointestinal manifestations are rare and including pancreatitis and hepatitis, which is inflammation of the pancreas and inflammation of the liver. The fifth one is respiratory symptoms. Apart from complaint of a dry cough, pulmonary manifestations are uncommon during acute HIV infection. There have been rare reports of pneumonitis, which is inflammation of the lungs, manifesting as cough, shortness of breath, hypoxia, without evidence for other infectious etiologies. The sixth one is neurologic findings. Headache, often described as retroorbital or behind the eye pain, exacerbated by eye movement, frequently accompanied by acute HIV infection. More serious neurologic manifestations of acute HIV infection have also been reported but are unusual. The first severe neurologic symptom to be recognized was aseptic meningitis, with severe headache, meningismus, photophobia, and the lymphatic pleocytosis of the cerebrospinal fluid analysis. Meningoencephalitis can also occur during acute HIV infection. Rarely, a self-limited encephalopathy may accompany acute HIV infection. The peripheral nervous system also may be affected by acute HIV infection, like Guillain-Barré syndrome. Facial nerve and brachial palsies have also been noted. The seventh one is opportunistic infections. Although usually associated with late-stage HIV disease, opportunistic infections can rarely occur during transient CD4 lymphopenia of early HIV infection. Among the opportunistic infections which occur during acute HIV infection, oral and esophageal candidiasis is the most often seen, and these factors responsible for the frequency of esophageal candidiasis during immune suppression of acute HIV infection are thought to relate to esophageal ulceration, which provides a local environment that promotes the growth of candida species, and that of the administration of antibiotics to empirically treat the symptoms of acute HIV may alter normal oropharyngeal flora. Other opportunistic infections that have been reported during acute HIV infection include cytomegalovirus infection, pneumocystis jirovecii pneumonia, prolonged and severe cryptosporidiosis. Acute HIV infection could be mistaken to some other diseases that resemble acute HIV infection, including infectious mononucleosis due to Epstein-Barr virus infection or cytomegalovirus infection, toxoplasmosis, rubella, syphilis, and disseminated gonococcal infections, viral hepatitis, and other viral infections. Fortunately, there are a number of symptoms and signs that help to distinguish these disorders from acute HIV infection.